Good morning. So, today we will be talking about topical fluorides. Fluorides, by definition, is used to describe those delivery systems which provide fluoride for a local chemical reaction to exposed surfaces of the erupted dentition. The delivery systems include measures designed for professional application in dental office. That's given by Stuckey in 1990. So, what are the indications of topical fluoride use? So, basically, it involves primary teeth, infant toddler, prevention of baby bottle tooth decay, and then again parental oral care, where the parental caries pattern is severe, and then again post-eruptive period, that is the rapid uptake of fluoride important for newly exposed enamel. Then again active caries that involve new carious lesions at regular maintenance. Secondary or recurrent caries adjacent to previous restorations, and wearing orthodontic appliances or bands, that's like bond brackets, etc. Compromised salivary flow, where there is compromised salivary, and of course teeth supporting an overdenture, exposed root surface, that is following periodontal recession, lack of compliance and efforts for daily dental biofilm, especially in special children that we are talking about, and then a low or no fluoride in drinking water. Then there is earliest early caries lesions. So these are all the indications of topical fluoride. Question. Yes. So once we know how and when how to use topical fluorides, we'll go on to the classification of topical fluorides. That include basically professionally applied and self-applied. So professionally applied to topical fluorides mainly includes higher concentration than self-applied. That is, self-applied has lesser concentration, less effective, but of course, it is can be used without any professional monitor. So professionally applied to fluorides have been applying fluoride agents to the teeth since early 1940s. After fluoride was identified as an element with karyostatic properties, it was summarized that fluoride applied to the teeth would be deposited in the outer enamel, making it more resistant to dissolution by acids. The professional topical fluorides are neutral sodium fluoride, stannous fluoride, acylated phosphate fluoride, amine fluoride, fluoride gels, fluoride prophylactic paste, fluoride varnishes, fluoride containing restorative materials, and controlled released fluoride devices. Neutral sodium fluoride is what we are dealing with now. This material is available in powder, gel, and liquid form. And the compound is recommended for use in 2% concentration, which may be prepared by dissolving 0.2 gram of powder in 10 ml distilled water. The preparate solution or gel has basic pH and is stable if stored in plastic containers. In 1942, Knudsen began a series of clinical trials using different techniques which required 4 visits within a short period. After prophylaxis, drying at 2% of aqueous sodium fluoride solution was applied for 3 minutes. And Knudsen concluded that maximum reduction in caries was achieved from 4 treatments, that is weekly intervals, and suggested that the series of applications should be carried out at the age of 3, 7, 11, and 13 years to coincide with the eruption of teeth. On the basis of above studies, Knudsen and Feldman recommended a technique of 4 applications of sodium fluoride at weekly intervals in a year, and also recommended 3, 7, 11, and 13 years as a specific age group for sodium fluoride application. In a few clinical trials on sodium fluoride dose after 1965, others have deviated from Knudsen's technique, changing weekly application schedule to 6 months or yearly. Abdul et al. In 1964 tried 2 applications per year and found 11% fewer DMFs after 2 years. Mercer and Muller found 27% fewer DMFs after 1 year by giving 2 applications per year. So the method of preparation of 2% sodium fluoride that includes can be prepared by dissolving 20 grams of sodium fluoride powder in 1 liter of distilled water in a plastic bottle. It is essential to store fluoride in plastic bottles because, of course, it reacts with silica of glass forming silicon fluoride, thus reducing the availability of free active fluorides for anti-caries action. So method of Knudsen's technique include initial cleaning and polishing. It is only in the first 4 applications. And 2% sodium fluoride is then applied in cotton applicators and permitted to dry on the teeth for about 4 minutes. After completion treatment, patient is instructed to avoid eating, drinking, or rinsing for 30 minutes so as to prolong availability of fluoride ion to react with two surface. Then mechanism of action of sodium fluoride include when sodium fluoride is applied topically, it reacts with hydroxyapatite to form calcium fluoride, which is dominant, and product of the reaction is the formula that is included. This is due to high concentration of fluoride, 9000 ppm in 2% sodium fluoride, due to which solubility product of calcium fluoride gets formed fast. And this initial rapid reaction is followed by drastic reduction in its rate, and the phenomenon is called choking off. This occurs because once a thick layer of calcium fluoride gets formed, it interferes with further diffusion of fluoride from the topical fluoride solution to react with hydroxyapatite. It is because of this reason that sodium fluoride, once applied, is left to dry for 4 minutes. And of course, advantages include relatively stable when stored in plastic containers, taste is acceptable, non-irritating to gingiva, and does not cause discoloration of tooth structures. Disadvantage is that patient has to make 4 visits in relatively short period of time. Coming to next one, stannous fluoride. Stannous fluoride is more effective, but again is not much used. The recommended approved concentration is 8%, that is obtained by dissolving 0.8 gram of powder in 10 ml distilled water. It is the technique that is introduced by Muller, and it included very less number of application of, and since for applications is not possible, there is finally only effect of 9 years treatment, that is filled for apparent 5 treatment has stopped, increment over 14 years, and was still to 23.8% lower in study group. Method of preparation include stannous fluoride solution has to be freshly prepared before use each time, and this has no shelf life. For convenient preparation, gelation capsules are priorly filled with 0.8 grams powder. Just before application, one capsule is dissolved in 10 ml of distilled water in a plastic container, and the solution is thus prepared is shaken briefly. Solution is then applied immediately to teeth. The 10 ml of solution should be sufficient to treat the whole mouth of a single patient. If any remains, it should be discarded and not used again. So, method of application of stannous fluoride. Recommended procedure for topical fluoride application begins with thoroughly prophylaxis. Just like with sodium fluoride, we have to actually clean and included with the pumice, including the proximal surfaces. This recommended frequency is once per year, and this is 8%. These are the byproducts that are formed, that is tin hydroxyphosphate, tin trifluorophosphate, and stannous fluoride, calcium trifluorophosphate, fluorostannate, and calcium fluoride is formed in low quantities. So the formulas, and other end product is tin hydroxyphosphate, and the metallic taste is due to that, and that is one of the disadvantages. Advantages include the recommended frequency is 6 to 12 months interval, much less than sodium fluoride. Disadvantage is sodium has to be freshly prepared each time before use, and bitter metallic taste can use gingival irritation. It causes brown pigmentation of teeth, particularly in hypocalcified areas around margin of frustrations. Coming to the one we use here mostly, that is acylated phosphate fluoride. And both forms contain 1.23% fluoride, generally obtained by 2% sodium fluoride and 0.34% of hydrofluoric acid. That is, acylated phosphate usually contain 1.23% of fluoride in 0.1 phosphoric acid at pH 3. Method of application: after thorough prophylaxis, teeth are isolated with cotton rolls. Both lingual and buccal side dried, and APIF solution is continuously repeatedly applied with cotton applicators. Teeth are kept moist for 4 minutes. Floss may be drawn to interproximal mixtures. APIF gel may be used in the same manner as topical fluoride, but it is self-application and can be used for different tray sizes. Coming on to the reactive part, that the byproduct formed is dicalcium phosphate dehydrate. Amount of depth of fluoride deposit is fluorapatite depends on the amount of depth at which DCPD get forms. Advantages include it is stable when stored in plastic container, no staining of teeth, gels can be self-applied. Disadvantage: cannot be stored in glass container because it may remove minerals from the glass edge. Repeated exposure of porcelain or composite restoration of true EPIP can lead to loss of material, leading to surface roughening and cosmetic changes. Coming to fluoride varnish was first developed in Europe in 1960, an attempt to increase the uptake of topically applied fluoride into channel. Some of the main fluoride varnishes used in are Durafat, Fluor Protector, Epoxylite, and Carex. Fluorafat is included in the fluoride lacquer was first introduced by Wern Pharma in Germany, and it's a viscous resonance lacquer. The important thing about varnishes, again, as per all the topical fluorides, it has to be properly isolated, and of course prophylaxis has to be done before that. And Fluor Protector is another fluoride varnish developed in 1970s by Fluor Protector Vivadent. So concentration of difluorosilane, concentration of 2%. Then again, epoxylite 9070 was described as a long-lasting topical fluoride coating, and this preparation is disodium monofluorophosphate, which is incorporated in a soft, flexible, pure polyurethane. And Carex is developed in Norway and contains low fluoride concentration. It's developed by A Node. Method of varnish application is important, as varnish application is the most effective one. Oral prophylaxis is of course done, teeth is dried, and first lower arch is taken up for application, and then upper arch as saliva collects rapidly on the lower arch. This is a small amount of varnish. Application is done with single tufted brush, and interdental floss can be also used for the interproximal area since varnish sets rapidly. After application, patient is made to sit with mouth open for 4 minutes. And patient should not clearly not to rinse or drink anything at all for 1 hour, not to eat anything, only till morning, as contact between varnish and tooth surface is maintained for 18 hours. Prolonged interaction between fluoride and enamel. Coming to fluoride gels contain cellulose compounds for viscosity. Gels are formulated to be threshold. They tend to be flow under pressure but remains viscous when not. Toothbrushing with dentifrices. Toothbrushing is a solution of gels, toothbrushing with prophylaxis basis, and applying dozen gels. Fluoride dentifrices include dentifrices provide sufficiently large concentration of fluoride to facilitate enamel remineralization. And some of them include sodium fluoride, acylate phosphate fluoride, stannous fluoride, sodium fluoride, sodium monophosphate, and amine fluoride. Some stupid formulations. Mechanism action, again, as the same of mechanism action of fluoride, that is hydroxyl formed to form fluorapatite. Special consideration must be given when recommending fluoride dentifrices for children under 6 years of age. So safety of fluoride dentifrices, certainly lethal dose and safely tolerated dose has to be noted before prescription of dentifrices. So with that, we come to the end of topic of fluoride. Basically, recommendation of toothpaste has to be noted with according to different age. And fluoride mouth rinse is another topic of fluoride, just in a karyostatic property that we can use. It is in general as an APF mouth rinse that is used. And then again, multiple fluoride therapy is another option, that is fluoride containing prophylactic paste plus topically applied fluoride solution with plus home use of fluoride dentifrices. So use of topical fluoride programs include safe and effective, relatively inexpensive, easy to learn, non-dental personnel can supervise, well accepted by participant, and little time required. Now, with that, we come to the end of topic of fluorides. We'll continue with systemic fluorides in the next session. Thank you.